So when we ask about sleep, one of the problems with it is primary care physicians tend to avoid this question because we all sleep and we're terrible historians of our own sleep. We don't know what our symptoms are unless we have a bed partner, typically. We just know when we start having those other conditions that maybe there's something going on. As I said earlier, snoring is considered more of a social disease than an indicator of something perhaps being wrong. And if you ask somebody, how do you sleep, you can end up in the majority of your conversation, you don't get to other systems that you need to talk to about them, with them about what's going on in their life. Because even in the sleep lab, asking questions about sleep to get clear, specific yes or no answers, there are some strategies, but even then, people like to give an essay response to a yes or no question. And fatigue is another one that's a little bit tricky because sometimes they'll say, well, I'm not sleepy, I'm fatigued. And so how do you make room for that story to come out? Because sometimes the fatigue is related to pain, but our ability to tolerate pain is decreased if our sleep is impaired. So sometimes you need to ask it both ways. Are you fatigued? Are you sleepy? How are you feeling? Are you feeling rested when you wake up in the morning? So trying to get to it is sometimes a hard thing to do. So we try to find out some ways to do that. Screening for obstructive sleep apnea is one of the easiest things to do because we can ask specific questions to get there. It's very common, and yet the diagnosis is very, very low. And even people who say, oh, well, I know I have sleep apnea, that's as far as they want to go because they don't want to move forward with the steps they think they have to do to get it diagnosed. I don't want to go to the sleep lab, or to get it treated, I don't want to wear that mask. And they think that it's that linear process instead of there's options out there and there's other ways to get at that. But since it is so common, we use something called a Somnia screener, and we'll go through that in some detail. So it's a mnemonic. There's another one that's commonly used called a stop bag or stop bang. We just have modified it slightly for our use, and so Dr. O'Brien, who's our medical director, has come up with something specific for each of the letters in Somnia. So S is for snore. Do you snore? And that question, people go, I don't know, I'm asleep. So a better way to ask it is, has anyone ever told you that you snore? Well, sometimes. Well, my husband says I snore, but I don't know. It's like, that's a yes. Are you overweight? In some cases, you know that the person you're talking to is not just overweight, they're obese, but even people who are technically obese based on their BMI do not like that term. It makes them feel bad. So we don't want to be condescending and pretend that they're underweight if they're obese. You just say, are you overweight? Or do you feel that you're at a healthy weight? And they can say yes or no. Are you male? Men have a much higher rate of obstructive sleep apnea until menopause, and we'll talk about that a little bit later. Nod off. This is a tricky one in terms of this mnemonic, but because people think technically nod off. Am I doing this? Nod off means, are you sleepy? Are you having a hard time getting through meetings or a movie, without like fighting sleep or going, I need to take a break and go walk around or get some coffee because I'm sleepy. I is for increased age. Are you over 50? And A is for apnea. Has anyone ever seen you stop breathing, or have you ever woken yourself up gasping or choking? For those people who say, I don't know, I sleep alone. Do you ever wake up going, that's an apnea. And the final S, Dr. O'Brien and I went round and round on this one. It's on the screener we have now, it's systolic, to remind you to ask about blood pressure. I prefer silent killer because technically obstructive sleep apnea is related to an increased diastolic on your blood pressure. Your lower number tends to be the one that's affected most by sleep apnea. And he said, well, I've never heard of silent killer. And Peter, our CEO, said, well, Google it. And the first 7 things that came up were silent killer hypertension. So I win. But either way that you remember it, the final S, so Somnia's is about high blood pressure. So if somebody answers yes to 3 or more of those, they're at increased risk. We weight the snoring in particular because if some of those other symptoms are occurring, we want to capture those people who are in that mild range. Another great example is Anne Fink, who you met earlier. She's okay with me telling you all this. She has sleep apnea, even though she does not fit the profile. And when she was first diagnosed, she had zero, except she had one. She had snoring. That was all she had. She was under 50. She was underweight. She was female, and yet she had, sleep apnea that was significantly impacting her life. So that's why we're trying to capture more people. The way that we operate with doing the home sleep apnea test, this is a prescribed medical procedure. So we have a standing order that says you have to have 3 or more yeses for us to be able to do that without you seeing somebody, right? So that's how we work that in our system. So as I alluded to, menopause and women, that's why that increased age, that 50, comes into play. Because for women, the heart disease risk goes up at menopause, and so does the risk for sleep apnea. And so those numbers start to even out, and sleep apnea and heart disease are linked. So we think that there is a strong correlation there. We believe it's the estrogen that has an impact on the ability of the muscles to stay firm during sleep. Diabetes is strongly correlated with undiagnosed sleep apnea.
Type 1 or type 2 or both?
It's type 2, the adult onset. GERD, or gastroesophageal reflux, because of the increased intrathoracic pressures that are generated when the body's trying to figure out that wake up or sleep or breathe thing. It generates increased work from the diaphragm to try to break through that obstruction, and it can push that acid from the stomach up into the esophagus and sometimes even into the mouth and erode the teeth. The insomnia piece, those 3 questions about dry mouth, urinary frequency, and morning headaches. And then mood disorders are also strongly correlated. People with depression and anxiety and bipolar are also at increased risk for obstructive sleep apnea. So I'm going to show you a little video about sleep apnea.
I snore?
Yeah.
See, I don't know if I snore because I don't hear myself, so.
Oh, he hears himself because sometimes it wakes him up. And he's like, baby, was I snoring? Yeah, you were snoring. It usually happens when he's on his back, and then he gets into that deep snore, like it's deep. And then he stops. His chest would stop moving and everything, he was not breathing. So I nudged him like, babe, wake up. And then he'd catch his breath. I'm like, dude, you just stopped breathing in your sleep. And I saved him.
Pam's a registered polysomnographic technician.
Poly what?
Polysomnographic means sleep study. She'll be the one putting the electrodes in.
Sleep apnea actually is a pretty common condition, which is most likely underdiagnosed and underevaluated because many people don't realize that they have it.
Well, every time I stop breathing, she, the next morning, yeah, sleep apnea. Yeah, sleep apnea. And I'm like, what is sleep apnea?
Well, sleep apnea is a condition where a person is unable to get air into their lungs when they fall asleep.
Every time the person stops breathing, they wake up. They stop breathing, they wake up.
And that exposes the body to a myriad of really adverse stresses.
And that does have consequences.
Irritability, can't focus and maintain attention.
They're unable to sleep in the same bedroom with their bed partner or spouse.
There's about a 7-fold increased risk of motor vehicle accidents.
It's linked with the obesity epidemic, to being linked with cardiovascular or heart disease.
High rates of stroke, diabetes, and even mortality.
And so now we got to fix it. Don't want to go out like that.
So, Shaq, one of the things that we talked
I'm meeting with the sleep doctor, my main man, Dr. C. He said he wanted me to be part of his sleep study.
We arranged for an overnight recording in which we could actually find out whether Mr. O'Neill has sleep apnea.
So tonight, electrodes on the head, and they're going to study the brain waves. Hopefully my REMs and my non-REMs. See, I read that, my rapid eye movements.
Oh, and the end is the what?
Non-rapid eye movements. So, hopefully I don't have it, but if I do have it, I know I'm working with the best people to, get it cured.
You all ready to go to sleep?
Yes, sir.
Okay, good luck with everything. We'll be here monitoring
So the evaluation of sleep apnea is a test while they're asleep. And every second of the study will be looked at, and then the physician will interpret it and make a conclusion.
To cut to the chase, you have moderate sleep apnea here.
Obstructive sleep apnea is a chronic condition which is eminently treatable.
All right, so you said there's the mask, the mouthpiece, and surgery.
Correct. The treatment of choice as of today for sleep apnea is to go ahead with nasal CPAP, the mask.
And is this forever treatment or just a 6-week thing? Or?
We generally regard this as lifelong treatment.
Getting a mask to fit effectively is often a cardinal part of effective treatment.
You have a mask here that I can look at?
If a person is able to use the CPAP device, it works almost 100% of the time.
No, yeah, this is pretty good. This is nice, I like it. Can I wear it to the club?
Yeah, absolutely.
Oh, this is nice.
Okay,
I like
good.
it. I'll do it. Since I've met with Dr. C, and I've been getting at least 7, 8, 9 hours of sleep a day. Feel good. The weight is good. Got a lot of energy. The relationship is good at the house. Everything is working.
So, as you could see, Shaq went with the whole sleep study. He was a VIP, so he did it at his own home, which was a nice bonus for him. But a lot of stuff gets monitored when you do a full sleep study like that. So insomnia is a little bit trickier. I mean, unless it's related to the sleep apnea, it's really about the story that people tell. It's not something that we typically are going to test for in the lab, because if they're not sleeping, we can't see if there's anything going on with their sleep. So it's usually attacked through behavioral stuff, environmental cues, cognitive behavioral therapy. And those questions about, I can't fall asleep or I wake up a lot during the night, a precursor or an indicator for depression, clinical depression for years has been insomnia. People who fall asleep fine and wake up in the middle of the night can't go back to sleep. That's fairly typical of somebody who's got untreated clinical depression. And actually the serotonin, the SSRIs, change the way REM happens. And so typically somebody who's on something like Paxil will have a delayed REM latency, and sometimes they won't have it until late in the night, which is interesting when you're working in the sleep lab and they do have REM-related worsening of their sleep apnea, because then we don't see it until 3:30 in the morning. And then it's too late to try CPAP on them and see if that'll effectively treat them. But they do that because if you take somebody who has depression and you watch their sleep and wake them up out of REM, and you do that over a period of a few weeks, they have improvement in their depression symptoms. So there is some relation between depression and REM. We're just not quite sure what that mechanism is. So there's lots of causes of insomnia, and I put cognitive behavioral at the bottom because it's the one everyone assumes is number one. But there's other things that we can do to try to hone in on whether it really is this by asking some other questions first. Do they have pain issues that make it hard for them to go to sleep? Is it environmental stuff? Are they watching TV too late or using their handheld device close to their face? Are they in an environment that's too noisy, disruptive? They've got pets or kids coming in and waking them up. Do they have untreated sleep apnea? Do they have restless leg syndrome, which makes it really hard for them to fall asleep? And then is it cognitive behavioral? So if you rule those other ones out first, then you can start to focus on that cognitive behavioral part of it and start to address some of the defeating thoughts they have, some of the behaviors that they have that are making it more difficult. Restless legs and periodic limb movement disorder are kind of like snoring and sleep apnea. They're linked but not exactly the same. Restless legs is a wake sleep disorder, so it's hard to go to sleep if you have restless legs. It's a tingly, tightening, creepy feeling, sort of like soda pop or bugs in your legs. Somebody who has this finds it impossible to hold still. They have to move to relieve those symptoms. And so when they try to go to sleep, it's usually worse in the evening, and they have to constantly move their legs, and they have a hard time falling asleep because of their need to move their limbs. It's more common in women, and it typically gets worse with age. Periodic limb movement disorder, on the other hand, occurs during sleep, and it happens about every 15 to 20 seconds, so it is a sleep disorder. And it is a sleep disorder not if the legs kick. but if the legs kick and cause an arousal. So that's why you need to test them in the lab, because you can ask the bed partner, do they kick? But if they're sleeping through it, it's not affecting their sleep. And sometimes we see people who are on dialysis. Most dialysis patients have significant periodic limb movement disorder. So in the sleep lab, when we say, oh, we have a dialysis patient coming in, as a scoring person, I go, I'll be scoring leg movements. Awesome. Because there's a lot of them. The sensations are hard for people to describe, and if you have somebody who's got diabetes, it's not the same as neuropathy. So you say tingling, and they're like, oh yeah, I have that, because I have neuropathy with my diabetes. It's different. And sometimes it can affect the arms and the upper body as well, but primarily it's in the legs. Typically it's a flexion movement with the toe, nice balance, that's just brief, like that. Just a little dorsiflexion with the foot that occurs. Sometimes it's more, and as it progresses over the course of life, it tends to become a bigger movement. And so you see patients who've got significant leg movements. It's like they're riding a bicycle in bed at night. But that movement helps for whatever reason to make it better. It's a tricky one to treat, and we'll talk about that a little bit later. Parasomnias is this huge umbrella for weird, complex behaviors that occur at night. It happens to be my favorite because I suffer from parasomnias. I have what tends to be what's called confusional arousals, but there are a number of them. The ones that are most common are sleepwalking and sleep talking, and the nightmares or night terrors. They're not the same thing. Nightmares are related to dream imagery that is specific, related sometimes to post-traumatic stress disorder. Night terrors are sort of like a nocturnal panic attack. If someone wakes up from a night terror, they typically have no memory of why they're freaked out. They're usually screaming, and it takes them a little while to kind of wake up enough to know that they're not in danger. Confusional arousals sort of look like sleepwalking. Usually it's get up and do something that's somewhat complex but makes no sense. So that's why I had my tonsils out, because I didn't snore, I didn't have hypertension, but I was tired during the day and I was having increased confusional arousals. And so I just got tired of my husband saying, hey, remember getting up last night? No. Oh my God, it was the funniest thing I've ever seen in my life. You sat up in bed, and you were like doing this, like you were walking like an Egyptian or something. My behavior was typical in that if someone, like if he would address me or challenge what I was doing, I would be cranky about it. You know, what are you doing? I'm looking for the vent into the living room. There's no vent into the living room. Yes, there is. You know, it's right here. You know, clearly I know what I'm doing. Don't talk to me. So yeah, it just got to be, you know, embarrassing. And I could tell when I was doing it, because the next day I'd wake up and I'm like, I am so tired today. And then I turn to my husband and say, did I get up last night? And he goes, why? And I said, well, I'm really tired, and my steel-toed shoes were in the middle of the bathroom. He goes, you know, that was about the sound I heard while I was watching TV. It was kind of a thunk. Yeah, that must have been you. I'm like, yeah. So had very large tonsils, had a sleep study. Yes, I was having a lot of REM, because every time I went into REM, I was kind of in this twilight zone, having a little bit of obstruction. So they took those tonsils out. Much, much better. Hypnic jerks, most of us are aware of. And it's one of those weird sleep jargony words, but it means, you know, like when you're falling asleep and you feel like you're stepping off that curb and you do that thing, that's what a hypnic jerk is. And then sleep eating, sleep driving, sleep sex, those are really complex behaviors, and they are linked to things like your SSRIs and Ambien. It's one of the reasons why they changed the dosing on Ambien CR for women, because we're more sensitive to it. So women should not have more than 5 milligrams of Ambien CR, or they are at much higher risk of sleep eating, driving, and sleep sex. And those other kinds of weird parasomnias. There's also something called REM behavior disorder, which I don't put in my category of regular parasomnias. Most of these occur out of deep sleep, sort of in that place of, as you're transitioning out of deep sleep and moving into a lighter stage of sleep, maybe going into REM, it's sort of this twilight zone area where people like me, who are kind of wired this way, tend to do this stuff. REM behavior disorder happens in REM sleep. Your voluntary muscles are supposed to be paralyzed and they're not. So you're supposed to have what they call REM atonia, which means you can't move. For people with RBD, they don't have that and they act out their dreams. So it tends to be pretty terrifying. They're usually violent. So I'm going to show you a little video so you can see what I'm talking about.
In this home video, a Japanese man makes the ritual moves of a samurai warrior, stabbing his imaginary opponent, then finishing him off with a flourish. All this time, the man is sound asleep. He suffers from a parasomnia, unpleasant and unwanted behavior during deep sleep. So do millions of Americans, including Mike Doyle. By day, he's a mild-mannered bank executive who lives with his wife in a suburb of Minneapolis. By night, he wanders the house in a deep slumber, acting out his strangest and wildest dreams.
Ran down the hallway and jumped from the top step and landed somewhere near the bottom. I got up and went back to bed, and the following morning I didn't realize what I had done until I sat down on a wooden chair in the kitchen. And I thought I was going to die because of how bad it hurt to sit.
What happens with parasomnias is that the brain tells the body to move, to walk, to have sex, to eat, to become aggressive, to become violent. It's the brain that directs the muscles and the rest of the body to engage in these activities.
Dr. Carlos Schenk, a sleep disorder specialist, has conducted pioneering research into how the brain triggers such behavior.
Wait. No.
In the documentary Sleep Runners, he's cataloged a range of parasomnias, including those who eat in their sleep.
A woman with sleep eating, every time she eats a bit of her brownie, she extends the pinky of her hand and nibbles on it, and that's no way that she would ever eat during the daytime.
This 21-year-old woman eats and drinks continuously over 2 hours while asleep in the dead of night. She starts munching on bread. A few minutes later, she washes it down. Then it's the bread again, then potato chips, the drink, and once more the chips.
The sleep eaters generally have partial awareness of what they're doing, but they don't know the full extent until the next morning. Then with horror, they will see all that they ate.
Here, it was a bite out of a frozen pizza.
And also, they really are very disgusted with how they ate, such as spaghetti and meatballs with their bare hands, or they make a tuna fish sandwich loaded with salt and pepper, or even a cat food sandwich.
A cat food sandwich?
They make a cat food sandwich, they butter cigarettes, they put coffee grounds, Coca-Cola, and eggshells in a blender, and then they blend it all together and drink it. It's bizarre.
Sometimes the bizarre behavior can be quite violent. This is a 21-year-old man suffering a night terror.
He responds by throwing a backhanded punch at his pillow, and then he growls.
Why are people responding to sort of primal fears in their sleep?
Well, I think it's the flight or fight response, that suddenly out of deepest sleep, you encounter a major threat and you have to respond either running away or fighting against the threat.
The parasomnias are considered a brain dysfunction, not a mental illness.
Most parasomnias can be diagnosed and effectively treated, and most parasomnias are not a function of a daytime psychiatric disorder.
But Mike Doyle feared the stigma, one reason he only reluctantly signed up for a sleep study at the Minnesota Regional Sleep Disorder Center. He's wired with hundreds of leads so that researchers can monitor his brain and body.
And I'll also be applying a snore sensor.
Such testing is critical because some parasomnias during the dream stage of sleep, known as rapid eye movement or REM, can be a precursor to brain diseases, including Parkinson's.
We identified a new disorder called the Rapid Eye Movement Sleep Behavior Disorder, or RBD, mainly affecting men in their 50s or older who were acting out violent dreams involving unfamiliar people or animals. After we followed these men along for a decade or longer, we realized that at least 2/3 of these men develop Parkinson's disease, which is a traditional neurologic disorder involving tremor and rigidity.
Mike's wife, Cheryl, is concerned. Her husband has been walking, talking, and occasionally raging at her in his sleep throughout their 8-year marriage.
He'd bolt right out of bed and would scream, yell. Sometimes it was just nonsense. there were dogs in the house and we needed to get the dogs out. The only time that I would probably run after him is if I heard the front door open or the garage door open.
He'd actually leave the house.
Yes.
What kinds of things would you notice, Mike, about these episodes?
Well, certainly the frequency, 3, 4, sometimes 5, 6 times at night.
Tonight you're going to learn to be an animal, to live like an animal and to die like one.
One of his recent night episodes involved the movie Cape Fear. Robert De Niro stars as an ex-con who stalks the family of a lawyer played by Nick Nolte.
There's a scene where the family is on the boat and they're in the river, and the family is trying to escape Robert De Niro, and they're all jumping into the river, and I dreamt I was on that boat. And I got up and out of bed and kind of got a running start and dove into our living room.
He actually pushed me in a closet, and that's when he dove on to the floor.
Basically just got up and went back to bed, and it wasn't until a couple of hours later that I woke up and wondered why the bed was wet. And I realized that I turned on the light, and here my knees were bleeding from having scraped my knees.
Have you noticed distinct personalities, a night personality and a day personality?
Oh, absolutely. He's not himself at night when he has these episodes. He's a totally different person.
Jekyll and Hyde?
Yes. Mm-hmm.
Sleep disorders have increasingly served as legal defenses in violent crimes, with mixed results. 2 years ago, this Canadian man was acquitted of rape after claiming he was asleep when he forced himself on a woman after a party. The two had been napping on a sofa. The defense called it sex somnia. In 1997, Scott Falater, a devout and devoted family man with no criminal past but a history of sleepwalking, stabbed his wife 44 times and held her under their pool.
It's something that is going to haunt me forever.
The Arizona jury rejected his sleepwalking defense.
We, the jury, duly impaneled and sworn in the above entitled action, upon our oaths do find the defendant guilty of murder in the first degree.
Do you think someone can be innocent of murder because they have a sleep disorder?
Yes, someone with a parasomnia can commit an act of murder and have no idea what he or she is doing in the process. So on that basis, yes, they should be considered innocent.
I need you to relax with your eyes closed, please.
During his sleep study, Mike Doyle is monitored overnight and through a series of naps, nearly 24 hours in all.
And he did have one very brief kind of confusional arousal from deep non-REM sleep.
In the morning, Dr. Schenk and Dr. Mark Mahald, a neurologist, go over the results.
During REM sleep, was there any evidence for REM without atonia?
REM sleep looks pretty good.
So, Mike and Cheryl get some good news. The sleepwalking does not appear to be the more serious REM behavioral disorder, RBD, the red flag for Parkinson's disease.
And the bottom line is you have obstructive sleep apnea that is superimposed on your sleepwalking. You did have one episode of confusional arousal with mumbling out of a slow wave sleep, which is very consistent with the sleepwalking history. But you had, mild to moderate obstructive sleep apnea, 25 episodes an hour.
The prescribed treatment includes a breathing device to prevent sleep apnea and perhaps a common sedative. By now, the Doyles share a simple wish.
I think just having what I would consider a normal night's sleep.
Getting a good night's sleep myself. Uninterrupted sleep would be nice.
For this couple, that is the ultimate dream. A sound sleep, unburdened by the terror of the night. I'm Chris Bury for Nightline in Minneapolis.
So that whole parasomnia thing, in adults, we tend to outgrow these kinds of behaviors. So if you have somebody who sleepwalks as a child, it kind of a function of all that deep sleep that they have. So it's usually we outgrow it. If you have somebody who sleptwalked as a child and then is now having a recurrence of these things, it's a good way to trigger that. Let me ask you about your sleep symptoms in terms of sleep apnea. Because just like me, I was mild, but I was having increased confusional arousals because of that obstruction and that disruption to my sleep. Same with him. It is a wiring issue, so there's only so much we can do. Circadian rhythm disorders, we talked about this a little bit earlier. So this is we sometimes call it advanced or sleep phase syndrome, but it's a circadian rhythm disorder. The delayed is most common. That's in the adolescents. We talked earlier about how the melatonin is secreted a little bit later, and then so they aren't falling asleep. They've got lots of homework. They're on their media. They've got TVs in their room, and so they fall asleep too late. And so a parent will say, "I don't know what to do. My child has terrible insomnia. They don't fall asleep till 2 o'clock in the morning." The first question to ask is, what time do they get up? Because if they're still getting 8 hours of sleep and they're being allowed to sleep till 10, they're still getting sufficient sleep. So they don't have insomnia, they're just falling asleep too late. The same happens with the elderly. They have advanced sleep phase syndrome where they fall asleep too early in the evening. So they're falling asleep at, say, 7 o'clock at night after they hit the early bird special. And then they wake up at 3:30 and they say, "I have terrible insomnia. I wake up at 3:30 in the morning." It's like, well, yeah, you got 7.5 hours of sleep. For your age, that's pretty good. You don't have insomnia, you have a circadian rhythm disorder. So the ways that we can do that, to fix that, is sometimes with a little bit of melatonin and also with some light therapy. So for adolescents, don't let them sleep in and get them some early morning light exposure. And for the elderly, get them some light exposure after the early bird special. Go take a walk in the sunlight or do something so that they can push that, like what Dr. Seisler talked about, move that that second wind syndrome back a little later so they go to sleep a little bit later and then don't wake up in the middle of the night when nobody else is up. Narcolepsy. How many of you have heard of narcolepsy? Okay. So this is a significant brain disorder that causes patients to just fall asleep when they don't want to. They have uncontrollable sleepiness. So signs and symptoms, that first one, that sleep attack, they just are so tired and they cannot, on their own maintain alertness. Cataplexy is a neurological condition. It's related to emotion typically. Frequently we see it with happy feelings. So laughter can make you kind of lose a little bit of muscle tone. It has to do with that link to REM sleep and that atonia. So somebody with cataplexy will go, gosh darn it, and then they might, and if it's really bad, they just go down and they're asleep, usually in REM sleep. They have hallucinations. There's two types actually. There's hypnagogic, which happen as you're falling asleep, and hypnopompic hallucinations. They're usually pretty terrifying. It's usually sort of, I'm being probed, there's a stranger in my room, someone's doing something to me, and I can't control it. Sleep paralysis means that you can have some alertness and be awake, but you're unable to move. Again, they think it's related to REM sleep and it not completely, being that wakefulness, non-wakefulness thing, and just like we're paralyzed in REM sleep, you have that sleep paralysis and you can't move. And then while the sleep itself is somewhat disrupted and not that nice, beautiful cycle that we saw for normals, naps tend to be refreshing. So if somebody wakes up, I always feel better after I take a nap. Somebody with sleep apnea does not feel better after a nap a lot of times because they're still obstructing when they go to sleep. Somebody with narcolepsy does feel better. So I do have a video about narcolepsy, but I did warn a group. I said, this is really disturbing, and they said, that's okay, we want to see it. I'm like, all right, just telling you. This is somebody who's got incredibly severe narcolepsy.
For Dee Dowd, staying active is important.
I try to take the dog for a walk at least 2, maybe 3 times a day.
Where you going?
I should really wear my helmet when I'm outside to be safer.
Rivers, come here. Come here. Here. Good girl.
I am scared to leave the house.
For Dee, simply walking the dog can become a nightmare because Dee has narcolepsy. Dee Dowd has fallen asleep while out walking his dog. But this isn't the first time. Dee's narcolepsy is so extreme, he can't participate in everyday activities without falling asleep.
I can't have a bath, can't drive anymore, can't really go shopping on my own. Can't play games. Go play cricket or football or whatever. I could never do any of that. I'd just go to kick the ball and fall over and fall asleep.
Dee is practically housebound.
To not know whether you can go out and come back again in one journey is really a worry. And you never know where you're going to fall down. You never know if you're going to get hurt. And you think to yourself you're going to get mugged.
Dee is totally dependent on his friend Karen Jones, who lives with him.
I rely on Karen 100% of the time.
It's time to wake up.
I need a shower though. You're going to stand with me in the shower.
I care for him a lot. I sort of give him a life, basically.
Karen likes to keep him busy.
It's good to do some chores and keep myself going, or else I'd literally sleep all day long.
Simple tasks can become extremely dangerous for narcoleptics.
I've broken my nose before, headbutting the floor, which is why it's a bit onto the side. I've really hurt myself quite a few times, actually. I went for a scan a little while ago, and I've actually broken every rib bar one.
Narcolepsy is a central nervous system or neurological disorder that is due to loss of cells in a particular part of the brain called the hypothalamus. And as a result, people have these difficulties with daytime sleepiness. People with narcolepsy are excessively sleepy.
You'll probably find me in sleep mode 18 hours a day. I have hallucinations, and they can be really frightening. When you have these dreams, you're getting sort of mutilated or chased, or animals are eating you and all them kind of things. I just exist in two worlds, really. And sometimes, quite often, I don't know which is the real world. As I wake up more and more and more, they can be passed over, but sometimes they actually last all day long.
Dee suffered from severe narcolepsy for 30 years before being diagnosed.
The average time from the onset of narcolepsy symptoms to a diagnosis of narcolepsy is about 10 years. And during that time, people may consider themselves or be considered by others to be either lazy or crazy.
Everyone thought I couldn't be bothered. Attitude problem.
To make things worse, sleep is brought on by emotion, especially happiness and humor.
Yeah, he's got food in the mouth. All right, sit up.
Before my diagnosis, I was constantly trying to evade emotions. And even at work, I didn't make friends. I was really an outcast.
Dee's diagnosis explained that in addition to narcolepsy, he suffers from cataplexy, a related muscular condition. It's cataplexy that makes him fall over when he's awake.
Cataplexy, the emotion-related muscle weakness, means that they'll often avoid situations that are emotionally charged. So where most of us would go out to have fun, to have a laugh, that's the last situation that someone with cataplexy would want to be in because it brings out their symptoms. So they're seen as antisocial, and this may be a very stigmatising disorder.
Dee withdrew from the world. He felt alienated, shunned. But even in private, intimacy continues to be a problem for him.
I miss being able to have a relationship, and sexual relationships are just impossible for me. You go to kiss them or fall on top of them and headbutt them, it's not good. Flatten them on, lying on top of them if you're making love and they can't breathe, and all I can hear is my nose whistling.
Just knowing that he has a condition helps Dee to cope.
You do like looking at me, don't you, girl? You're the only girl that gives me kisses.
There is no cure for narcolepsy or cataplexy. The standard treatments are helpful. They help manage the disease, but they certainly don't cure it, and they're not as effective as we would like them to be.
Despite this, with Karen's constant care, Dee is beginning to venture out and build a social life. He's taking a day trip to London. Millions travel halfway around the world to visit the capital city every year. Although it's only half an hour away for Dee, it's almost out of reach.
I haven't been to these parts of London for about 30 years.
The excitement may prove too much for him, but I think he'll give it a good go.
Okay, let's go some fun.
Yeah, come then.
Dee may have been overconfident.
Dee's got very excited, and as you can see, he's fallen asleep, so he's going to have a nap for 5–10 minutes.
It takes them half an hour just to get out of the station. First stop, Buckingham Palace.
The flags are full.
But Dee doesn't see very much.
I've had moments when I've fallen asleep crossing a road, for example. The cars just bid. They want to get on with their journey. They're not even worried that I might be having a heart attack. People quite often think that I've been on drugs or that I'm drunk, when I've not had anything at all.
When Dee does fall asleep in the street, hardly anybody ever comes up to ask if he's okay. They'll just walk past and give snide comments.
Through no fault of his own, he's treated as a pariah.
I have such a lonely life because of it, and mainly because of the lack of understanding from other people.
I can't stop smiling.
Dee is learning to live with his condition and accept who he is.
I am who I am, and narcolepsy and cataplexy is part of my personality.
So he is, of course, very severe. Most patients do not have that level of severity with their cataplexy, but it can be quite debilitating. And that length of time between onset of symptoms and diagnosis also makes it difficult. Most people start to experience some of the symptoms in young adulthood. But people think it's just because, oh, I'm studying, I'm going to school, I'm so sleepy. And all of the symptoms don't show up at once. They tend to show up piece by piece. And so maybe someone will start with some sleep paralysis and the sleepiness, and then maybe have some of the hallucinations, or maybe they'll start to have some cataplexy. So it's not all of a sudden you have everything, and that's one of the reasons why it's kind of tricky to diagnose it. It is also important to make sure there's not an underlying condition, because somebody, especially somebody who's in middle age who comes and says, I think I have narcolepsy, I'm so tired all the time. If they don't have all of these symptoms by then, it's less likely. And if they snore, they just may have significant sleep apnea that's causing them to be excessively sleepy. People with untreated sleep apnea can have the kind of debilitating sleepiness that narcoleptics have, but they have a very different thing going on. Any questions on that?
I recently had a patient that told me that not only would he fall asleep while driving, which I of course am very concerned about, but he would fall asleep at work in the middle of cleaning something, which is nod off and be gone for a few minutes and then come back. Is any way to differentiate what might be narcolepsy versus some other sleep disorders?
The reason that we send people to the sleep lab for diagnosis of narcolepsy is twofold. One is to make sure they don't have obstructive sleep apnea. So if somebody has obstructive sleep apnea, they can still have narcolepsy too. But you can't diagnose the narcolepsy until you've adequately treated the sleep apnea. So for example, a typical person who's coming in with narcolepsy symptoms, We'll order a split night study. So do they have sleep apnea? If yes, we put them on CPAP and they go home in the morning. If they don't have sleep apnea or any other sleep disorder, then everybody's a little different. At Rose, we let them sleep until they woke up unless it was past 10 a.m. And then when they would get up, we would change their wiring a little bit, and then within an hour and a half to 2 hours of starting, they have their first nap. So we do a multiple sleep latency test, which is what the gentleman with confusional arousals did. That's why he was there so long. And then every 2 hours, you get a nap opportunity to see if you fall asleep. So the first thing is see if there's something else going on. You can start to kind of get an idea of whether that's happening by asking some deeper questions that might be related to the sleep apnea, like the snoring and some of the other comorbid things, like do you have hypertension, those kinds of things. Typically, if you have somebody who's of normal weight, who has no history of snoring, no other comorbid conditions, but they're excessively sleepy, you can go ahead and order a split night study. They're probably not going to have sleep apnea, but you can't diagnose the narcolepsy without the full test. They need to have a mean sleep latency of under 5 minutes. They need to have REM sleep on at least 2 of those naps, and they do 4 or 5.
Follow-up question, how would cannabis use cycle into all of that?
Cannabis can have an impact on REM. So I had a gentleman who had been using a lot of cannabis and then didn't before he came in for a sleep study, and as a result he had a huge REM rebound and had tons of REM that night because it tends to suppress our REM a little bit. So it can have an impact, and as we saw earlier, people who aren't getting adequate REM will not have good mental rejuvenation, and it can cause them to be sleepy. It depends on, you said he is a he. Falling asleep while cleaning things, you know, if it's on the night shift and if it's happening while they're sitting, then you go, maybe you're just sleepy. I did have, the most severe narcoleptic I ever saw was somebody who would fall asleep making himself a sandwich, and, you know, marmalade was all over everything because he could not, he was standing up, and other patients that, you know, the rule is you can't sleep between nap opportunities when you're doing an MSLT. It's like, okay, let's get you up and move, and you'd come into the room and they'd be like this. Just like dozing up against the walls, like, come on, you can't sleep, let's go. So those people, it just really is a sleep attack, they can't help it. So it sounds like somebody might need some further testing to figure out what's going on, but the cannabis can have something to do with it, and yeah. But unfortunately, no way to clearly diagnose that one without the full test. Other questions on the disorders? Fascinating stuff, at least for a sleep nerd like me. Okay, so quiz number B, letter B. All right, true or false? It's easy to ask and answer questions about sleep. False. But now that you're so well educated, it's going to be easier. True or false? Fatigue and sleepiness are interchangeable terms. False. Sometimes they are, but not always. All of the following are true about obstructive sleep apnea, except it's as common as asthma and diabetes, it's largely undiagnosed, it's highly treatable, and it's not very dangerous. D, not very dangerous. Okay, fill in the blanks. S, snore. O, M,
Nail.
N, very good. I, yep, A, and S,
Systolic.
very good. Or silent killer, very good. When using the Somnia screening tool, how many yes answers are needed to justify OSA testing?
You said 3, but it says 4 in the handout.
That's correct. I didn't change it. We originally had said 4, but we talked to the folks at ResMed, and they were saying that it's appropriate given that we're trying to capture those mild to moderate to make it 3. So yes, good catch. Fix that little error. I didn't catch it when I edited. At menopause, what conditions in women begin to match the prevalence seen in men? cardiac disease and OSA, breast cancer, dementia, and insomnia. That's correct, cardiac disease and OSA. OSA is highly correlated with diabetes, high blood pressure, insomnia, mood disorders, A and D, B and C, or all of the above. That is correct. Insomnia may be a cognitive behavioral issue. Name 2 other causes of insomnia. Pain? Yep, environmental. Restless legs. Sleep apnea. True or false? If a patient has restless leg syndrome, then he or she will also have periodic limb movement disorder. False, that is correct. True or false? Holding still relieves the tingling, tightening sensations of RLS. False, way false. The opposite. Name 3 common parasomnias.
Night terrors.
Yep.
Sleepwalking and talking.
Yep, that's actually 3. Good job. Any others?
Confusion arousals.
Confusional arousals.
Hypnic jerks.
Hypnic jerks. Very good. Advanced sleep phase is a disorder most typically seen in elderly. Just think advanced age. Delayed is, like me, delayed adolescence. Narcolepsy is often diagnosed, A, in young adults, B, in patients over 60, C, in children, and D, by observation only. In young adults, correct. Which of the following symptoms of narcolepsy are described in alien abduction stories? Circle all that apply. I can't move as the aliens probe me. Sleep paralysis and hypnagogic hallucinations. Very good. All right. You guys want to take a little break? Okay.